you have studied that these drugs can be used in hypertension. Okay, hypertension. But then, which is the most suitable drug for this patient in this situation? You have to choose. The patient might be having some contraindications, might be having some comorbidities, which may prevent you not using this drug, or the drug of choice you will decide the drug of choice in that situation. So these clinical pharmacology sessions are designed in a way, first of all, two objectives: to recap what you learned during the block and to stimulate your thought process, how to choose a drug wisely. I remember we did in CVP block. Don't you remember? We did in POD the name of LGD, and we did in CVP, we did in neurosciences, you don't remember. I was the one who did in CVP. We presented so many cases. Okay, so let me start. My colleagues are very late. Okay, I cannot read the whole scenario, you just read, absorb the situation, and then I will ask you some questions. Any difficulty? Did you understand the scenario?
Yeah.
Okay. Let's go. What is the most likely diagnosis in this case?
Duodenal ulcer?
Which one?
Duodenal?
Gastric.
Okay, gastric and duodenal. If you feel it is duodenal, why do you feel it is duodenal ulcer?
Because it comes back, it gets better after meals,
Okay.
and then it, which is with duodenal, they decrease after meals, whereas with gastric, it increases with meals.
Okay.
And then it comes back after 2 to 3 hours because of the digestives again happening. So it should be duodenal.
Good. So why do you think it is gastric ulcer? She's right. Do you agree with her? So most probably from the clinical grounds, come here. It seems that it is a duodenal ulcer. Okay, see this. So this duodenal ulcer is associated with H. pylori infection.
Yeah.
Okay. How do you manage this patient?
PPI.
PPI, antimicrobial. Which one? Triple therapy is the preferred choice. Triple therapy consists of one PPI, erythromycin,
Amoxicillin,
amoxicillin. So triple therapy, 2 antibiotics plus a PPI. Two antibiotics and one PPI. Now the question is, would you add sucralfate as an ulcer healing drug to this regimen? If you know the answer, please raise your hand. Yes, please.
I don't think we use sucralfate with PPI.
Okay.
Because sucralfate is activated with the this is the mechanism of action.
Very good.
So we use the PPIs who are antagonizing the action.
So not only PPI, you won't use sucralfate in combination with the H2 receptor antagonist or antacids or PPI, any other. Anything which increases the pH of the stomach will actually decrease the effectiveness of sucralfate. So this combination is irrational. Do you agree? What is the mechanism of action of sucralfate from boys? How does it act? This is the one classical example of drugs acting through.
It coats the ulcer, so it needs acidic.
Okay, so in POD and in several other times, I have repeatedly emphasized this concept that drugs act through different mechanisms. Majority of the drugs, more than 95% of the drugs act through receptors. Receptors can be cell membrane bound or the enzymes or whatever, several receptors. Some drugs act chemically through chemical action like antacids, like heparin, other things. And some drugs act physically. And one example which I mentioned in the last block in diuretics was osmotic diuretic, mannitol. And this is another example, classical example of drug acting through physical action. Drug does not participate in any chemical action. Drug does not act on any receptor, just presence of sucralfate on the ulcer carter makes a gel and prevents the interaction between the acid and the ulcer site. So it protects the ulcer from the HCl, so just provides a physical barrier between the ulcer carter and the HCl. So in this way, then allows the body's natural defense mechanisms to heal the ulcer on its own. So it is a physical action, mechanism of action. However, 1 week later, the patient was switched to a regimen containing a PPI combined with bismuth and 2 antibiotics, metronidazole and tetracycline. The question is, what is this therapy called and why was it given in this patient?
Quadruple therapy.
Quadruple was, why was it given 1 week later?
Because it failed.
So resistance you don't know, but the patient actually 1 week later, the patient most probably might have complained that he is not having any benefit in his symptoms. So 1 week is sufficient to monitor the clinical improvement. In this case, it is highly likely the patient complaint continued. He did not report any improvement in his symptoms. So it was assumed that triple therapy is not effective in this patient, so he was started on quadruple therapy. Is that clear? Come on. Okay, see this case? Okay, see this case and absorb the contents. Any question?
Gastric ulcer.
And the sets?
Yeah.
I haven't asked any question about that. Okay, just absorb the scenery first. It was gastric ulcer. The patient is taking multiple drugs for hypertension and depression, and some over-the-counter medications for her headache. Now the questions. Do you think any of the drugs she is taking might be responsible for her current condition?
Yes.
As I said, she is taking over-the-counter. And what is the most commonly used OTC NSAID?
Ibuprofen.
Ibuprofen is the most commonly used. Aspirin people don't use nowadays. It is mainly used as an antiplatelet. But one OTC drug which is NSAID, which is available over the counter and widely used, is ibuprofen, available in the name of Brufen over here. Okay, you mentioned this. Raise your hand if you know the mechanism how NSAIDs may cause potentially gastric ulcer. Yes, please. So prostaglandins are responsible for mucus production.
And also
Hold on. Okay. So which prostaglandins are responsible for the production of mucus?
PGE2.
PGE2. And apart from that, production of mucus, prostaglandins are also responsible for decreasing the production of HCl in the from the vital cells. So those prostaglandins are under the influence of which COX? COX 1 or COX 2?
COX 2.
Oh.
Oh, one.
COX-1 is
Protective.
constitutive. It is always functioning. It produces some physiological, very vital functions like protective mucus production in the stomach or maintaining the renal blood flow. So these are the constitutive functions of COX-1, whereas COX-2 is inducible. It is not constitutive. Whenever there is inflammation, injury, it is induced, thereby leading to the production of several prostaglandins which are inflammatory in nature. So in the case of inflammation, what is required? Inhibition of COX-1 or COX-2?
COX-2.
COX-2. So the drug she is taking, most probably ibuprofen, it is non-selective. So that also inhibits COX-1, which will also block the constitutive functions of COX-1, thereby leading to the decreased production of mucus, which is protective, and perhaps minor action is increased production of HCl, which is also destructive. Both of these things may be responsible for development of this gastric ulcer. Is that clear?
What else? What else the mechanism of prostaglandin?
Increase activity.
And what else the cell turnover? It's responsible for cell turnover. So remember that we said it's more than one mechanism. That's why it can lead to ulcer. Remember we focused that it's either H. pylori or non-steroidal anti-inflammatory because they do through multiple pathway leading to ulcer or peptic ulcer. I'm not good today.
Is there any drug which can antagonize this ulcerogenic mechanism? Very specific. Prostaglandin, that is misoprostol. Misoprostol is a very specific prostaglandin analog which can block the ulcerogenic action or side effect of prostaglandin inhibitors. What are the other clinical uses of misoprostol? Induction of abortion before 24 or 23 weeks after pregnancy. Did we cover this? In POD we covered, and we will again cover in endocrine control. The following case is from PBL. That was last year. I don't remember whether this it was. You didn't use it? Okay, so forget about the title. It is not from the PBL. So that student is taking an antibiotic for treating diarrhea for 2 weeks, and she is coming now to ER, abdominal cramps, and once again diarrhea. She is taking a drug for diarrhea. We do not know what happened, whether she improved or not during these intervening 2 weeks, but she was given the drug for diarrhea, and she has presented once again with diarrhea and abdominal cramps for 1 day. So it seems that we can assume safely that during these 2 weeks she improved, but once again the diarrhea has restarted. Okay? Hypotensive, tachycardic, fever, low grade, tender abdomen, and CBC shows mild leukocytosis. Her stool sample was sent for toxin analysis. Clear? Let's ask the question. What is your probable diagnosis? Pseudomembranous colitis. Caused by? Caused by? No, caused by, not caused by.
C. difficile.
Which one?
C. difficile.
Clostridium difficile. Okay. What are the possible causes of this condition in the present case?
Antibiotic induced.
Clindamycin? Which antibiotic was used here?
And remove the mask.
Clindamycin? What do you use clindamycin?
No,
Here?
you didn't mention this. Clindamycin causes the pseudomembranous gland.
Only clindamycin? Which drug might have been used in this situation to treat
Erythromycin?
diarrhea? Fluoroquinolone. Most probably perhaps cyclophosphamide. Fluoroquinolone was perhaps used. So since it is broad spectrum, it is most likely that fluoroquinolone, especially cyclophosphamide, was used in this case, which initially treated but later on caused pseudomembranous colitis. Do we need to repeat the pathophysiological mechanism of how Clostridium difficile causes pseudomembranous colitis? You know that. What other antibiotics can cause this condition? One you mentioned already, clindamycin. There is one other widely used. At least you should remember three drugs:
Ampicillin?
fluoroquinolone, ampicillin. Fluoroquinolone, especially cyclophosphamide, clindamycin, and ampicillin. These are the most notorious for causing pseudomembranous colitis. How do you treat this condition?
Oral vancomycin.
Oral vancomycin or oral metronidazole. Would you use antidiarrheal drugs in this condition? None? No any? In my lecture, I delivered 4 classes of antidiarrheal drugs.
Because here it's
You can't say blanketly that you can't use. There was one drug, one class of drugs, which I specifically mentioned, which has some unique mechanism of action. The class of drugs containing kaolin and pectin, they absorb the toxins.
Is it active charcoal?
Activated charcoal, kaolin, pectin, these are the drugs which absorb the toxins and then they get rid of the toxins. You can't use anti-motility drugs. You can't use other antidiarrheals, but one class of drugs you can safely use without prolonging the duration of the illness. Okay, see the scenario. Fatigue, right abdominal pain, abdominal distension, jaundice, endohepatomegaly. More information. Having asthma, heavy drug user, lab results, WBC normal, HP almost normal, platelet count on the lower side, blood normal, urea and electrolytes normal, electrics deranged, all enzymes increased, albumin low or high or normal.
Doctor, will you give us the normal values in the exam?
We will give you in the examination, we will give you the normal variables of not the common things, but uncommon like this. But hemoglobin you shouldn't expect. Or the normal value of normal blood pressure you shouldn't expect. Okay, you should figure out. But the ones which are uncommon, we will give you. Don't expect from us the normal value of serum creatinine or something like that. You should know. So is this albumin normal or high or low?
Low.
Low. And bilirubin?
High.
On the higher side, okay. Look at the serology, hepatitis B serology, surface antigen positive. We used to call it Australia antigen. Do we still call it surface antigen? In my student days, the common use was Australia antigen. Because it was the first time it was discovered in Australia.
Australian
Australia.
antigen?
Yes. Do you still call it?
HBS.
Australian
Australian antigen.
antigen. Did you ever take
What
it
do
in
we call
clinical
it?
sessions?
Australia.
Australian antigen, because
Good
it was
surface
first
antigen.
coming from Australia. This is my first.
When I was intern, student, the common term we used Australian antigen. When it was made positive, it was written Australian antigen positive. It didn't call surface antigen at the time. Okay.
But now we have more antigens. Now we have core and
No, we used to call surface antigen at the time, but more commonly it was Australian antigen. Okay. So surface antigen was positive, surface antigen negative, and core IgG positive. So based on this serology reports, what do you think? What the patient is having?
Chronic
Chronic?
hepatitis B.
Okay. What are the treatment options?
Interferon.
Interferon, lamivudine. Interferon and lamivudine for hepatitis B. If he is treated with interferons, can you say? What is the mechanism of action of interferons? Anybody? Yes?
Phagocytic.
Okay. Okay. So it basically is endogenous glycoprotein, which is released as a result of viral infection. So it activates macrophages. It doesn't have in the viral activity directly, but causes the macrophages to activate and kill the virus.
There was an overlap of sessions. Did you?
this is the male thing.
No, she came to the female. They were using it. She said that she left. So now George is coming again.
But I know they are going for the Kingfisher Prize Laureate lecture, which is going on in the male theatre.
She said College of Science.
It is our block. Yes.
We booked it.
We didn't book it, was there in the schedule.
After
We
one
didn't book
week.
it. What interferon products are available and how do they differ from each other? From boys are not interacting. Yes. Interferon, and then there is other pharmaceutical preparation for those pharmaceutical interferon alpha. Pegylated, peg interferon. What is the difference between normal interferon and pegylated? Why does pegylation confer the drug the longer half-life?
Because it is longer, so it has less metabolism and it's longer.
Okay, longer means longer in terms of the length.
Increase size.
Hmm? Okay.
It's an increased size.
Yes, increase the size of.
Increase size of the interferon.
Okay, very good. So the same is in COVID. You are not seeing you are not aware of the current affairs. Pfizer vaccine, COVID vaccine, it is pegylated, COVID vaccine. So remember our lecture in POD block, the most important factors affecting the absorption of the drug from the site of administration. The first most important, single most important factor which affects the absorption of the drug is molecular size of the drug. So interferons are low molecular weight, so they will be quickly absorbed from the injection site, and since they follow the first order kinetics of elimination, quicker the absorption, quicker the metabolism, quicker the elimination of the drug. So if you make the drug pegylated, that means you are basically increasing the size of the molecule. By virtue of increasing the size of the molecule, you are hindering or hampering the absorption of the drug from the site of administration. So the absorption will be slowed down, and so hence the metabolism and elimination will be slowed down. Generally, if you use interferon, you may require maybe more than once the day doses. But with pegylation, you may require once weekly or 2 weekly doses of interferon. So this pharmaceutical preparation is just to increase the size and hence duration of action of the drug. What are the adverse effects expected with this treatment of interferon?
1 month.
Hmm?
1 month.
Bone marrow suppression. Most important. Most important. The moment you admit the drug on the same day, the person will feel, first of all, fatigue, flu-like symptoms. Flu-like symptoms. The patient is just like having flu. So these are the common symptoms. Okay. Another case.
Doctor, I have a question.
Yes, please.
In the first case, it was also Hep B. Why didn't we give the nucleotide or nucleoside hormones?
It's one case. It's one case. You just
So,
gave
so you
options
mean we
of
can't
treatment.
give it? It's just,
Yes.
okay.
Okay. Did you see the case?
Yeah.
Now what would you do?
Interferon alpha, interferon beta gamma.
Okay. Now she's a nurse. If she's a nurse in Kingfisher Hospital,
She's vaccinated.
even you as a medical student, you won't be allowed to enter the hospital to touch the patient if you are not vaccinated. So we can safely assume that the nurse is vaccinated with hepatitis B. In that case, you will go for the full treatment, full blown treatment, or something else.
No,
This is known as post-exposure
prophylaxis
prophylaxis.
of PP.
PP, post-exposure prophylaxis. So first of all, determine whether the patient is vaccinated or not. If she is vaccinated, which we can assume she must be, then do you need full-blown vaccination once again for that?
No.
So if not, but you have to go for additional prophylaxis, even though she is vaccinated, what would you do? Immunoglobulin, and hepatitis immunoglobulin, IgG, high dose, these are the drug of choice. So what else can we do? You can give?
Immunoglobulins, and if she is not vaccinated, if you check the antibody levels in which are low, then you can give her a booster or you give her like a vaccination.
Dose.
But now because we are giving immunoglobulins because we don't know her antibody status. Like she is vaccinated, but what is the level of antibodies that she has in her system, which may be low. So you don't want to take risk. So you will give immunoglobulin. But if you know the antibody levels, which are high enough, then probably you don't need any.
Okay. So a patient okay. Any question? Any question? Can you interpret the lab results?
Yes.
If you don't, please ask me the question.
What is your diagnosis? Cirrhosis or chronic liver disease.
So serology of hepatitis C is antibody is reactive and RNA is also positive. So this is a CLD due to hepatitis C, chronic liver disease. You already made the diagnosis. patients with therapeutic options.
Depending
Interferon?
on the symptoms, if he's having portal hypertension.
Combination of.
That we will talk about Santosh will talk about in the coming slide, the treatment of complications and other symptoms of CLD, but specifically for hepatitis C. eh,
Combination. Interferon with ribavirin.
There may be needing some official session. In your schedule, do you have half an hour tomorrow or today or tomorrow? Hmm? Today the last day.
Tomorrow you have some sessions.
The session is 2 hours.
Parallel session.
What do you need?
You want to do it?
Okay, actually, the email was sent to, the link was sent to Hasmukh for lecture in drugs on viral hepatitis. The lecture was prepared by someone else and there was some miscommunication. Do you remember that? So some drugs which are now widely used are direct acting antiviral drugs, which were missed. So you are not aware of these direct acting antiviral drugs, which are nowadays the most widely and very safe oral drugs. So interferon is no more used in hepatitis C.
You had a people case as well. Your people case where there was Hep C.
What is the drug you are talking about?
I mean, protease inhibitors and NS3A, NS3B, NS4A, NS5 inhibitors, direct acting membranous. So you didn't cover. Did you cover in PBN or not? It was missed. Anyway.
So it was someone else who was supposed to take the lecture, and by mistake the link was sent to Dr. Atul. All of a sudden she
In one of our
was caught in
students.
surprise.
Okay, now forget about the previous slide. So I'm not going to ask those questions because you didn't cover. Okay, please go ahead.
So during the last 5 months, this patient presented to emergency with repeated episodes of hematemesis. So you know there is a CLD, and he might be receiving his treatment for FC, but now for any any patient with CLD or cirrhosis would have some complications, as we discussed previously. So now this patient has been presenting with repeated hematemesis, and now this time he is presenting with altered consciousness for 1 day. So what do you think? What's happening? Hepatic encephalopathy. Very good. And on examination, we'll find there's a pallor, there's icterus, there's some dehydration as well, and there's pedal edema. Okay, so you know why we have pallor and why this pallor? Anemia. And anemia would be due to? Yeah, so one cause would be hematemesis, like blood loss. There will be a few other mechanisms as well. Yeah, so splenomegaly can lead to hypersplenism, which will sequester RBCs, platelets. So it can lead to anemia, thrombocytopenia. Yes, yes. And we have icterus. Why? Yeah, because of the so icterus is what? How is it different from like when you see yellowing of the sclera? That's icterus. And so there's edema, and why would there be edema? Hypoalbuminemia. So they are not making enough proteins. They are not losing it, but they are not making it. So it's not protein loss. It's this problem with the synthesis. Liver is not working. In nephrotic, it will be protein loss. Okay. Now, see, this is just by design. This podium is facing directly to the girls. Okay? Because some of my friends sometimes complain that some faculty just are looking at the girls and not looking at the boys. So don't feel left alone, okay? So, so you know the edema reason. So there are other mechanisms for edema. We will talk about that. Which would you want to?
RAS system activation.
Very good. And why RAS would be activated?
Because hypoalbuminemia and the patient is dehydrated, this will decrease the blood flow to the kidneys, activates glomerular cells, release of renin, angiotensin 2, absorption, aldosterone absorption of sodium and water.
Very good. So there will be more aldosterone, but the activation of RAS is not just because of hypoalbuminemia and less vascular volume, but also there are release of nitric oxide and other vasodilatory compounds which lead to vasodilatation and low flow to the kidneys. Good. So that contributes to all the aldosterone, more fluid absorption, but then third spacing because we don't have enough protein in the vasculature, so more third spacing. So on examination we have tense and distended abdomen, umbilicus is everted. So why abdomen is tense and distended? Ascites. And why umbilicus is everted? Again because of ascites, no? So because of the distension in the pressure. And why would there be ascites?
Portal hypertension.
Yeah, so one thing is portal hypertension, the other thing is the same reasons which you explained for the edema, so low oncotic pressure because of hypoalbuminemia, and then as you explained because of the activation of RAS, more aldosterone which is more retention of water, and that then goes into third spacing. So, and then there's another thing which I think you should have done in PBS. In cirrhosis, there's also problem with the lymphatic drainage. So there's portal hypertension, but also there's a problem with the lymphatics of the liver as well. So that also contributes. So there are many things, but mainly portal hypertension and low oncotic pressure and more fluid retention because of high aldosterone. Okay. So liver is not palpable. Why? So shown. And why spleen is palpable? Portal hypertension. So how the portal hypertension goes to the spleen? How is it connected?
The spleen and the spleen is very formidable.
Yeah, so splenic vein is also as a tributary of the portal vein. Good. So fluid thrill is was present. Ascites. So okay.
Okay, let me ask the question from them. What is the difference in interpretation of fluid thrill and shifting conveys? You are hold on. Okay,
That's fine.
Yeah?
What do you mean?
Shifting dullness and fluid thrill. What is the difference?
The technique is not to press and then you feel dullness, and then you ask the patient to shift to their lateral side, wait
Okay.
for half a minute, and then repeat it. The fluid thrill is when you ask the
So
patient.
when you repeat it, what will happen?
If it changes to resonant, then the fluid did shift to
Okay.
its side.
Okay.
Fluid thrill is when you ask the patient to put their hand in the middle, and you put your hand on the other side, and then you flick, and then if you feel the waves hit your other hand, then it's the side.
So both of these things are indicating there's some fluid in the abdomen.
So
Besides,
the issue is there that these two you mentioned the procedure. But what is the difference in the interpretation? Sometimes it is likely that the fluid thrill is absent, but shifting dullness is positive. What is the difference?
Maybe early stage of ascites.
Early stage, you can't say early stage, but it is the low amount of fluid.
Lower volume.
Lower amount of fluid will be demonstrated in shifting dullness. You can see that the fluid is shifting from one side to other side. When there is a gross edema, cut off fluid, then you can easily demonstrate through fluid cell, through the gross. But whenever it is not gross ascites, you can still feel why shifting dullness when amount is low.
and bowel sounds were sluggish.
This goes aside.
Yeah, it can be because of ascites, and also the motility might be reduced as well, which may be due to Alias, and alias might be due to
function of the
function, which might be due to
either tumor or anticis.
like, so if there's more aldosterone, which will retain what sodium and water, but it will get rid of something,
That's it.
potassium. So hypokalemia can lead to functional alias. So that may be another contributing factor. So there may be hypokalemia. And on CNS examination, this patient is irritable, drowsy, and not oriented to time and space. So this shows hepatic encephalopathy. So now the question would be, so you interpreted the findings, huh? So you said cirrhosis, and we also ascites, hepatic encephalopathy, all those things. So before that, so what is the mechanism of hepatic encephalopathy?
Ammonia.
Ammonia. And where is this ammonia coming from? So why do we have more ammonia in cirrhosis?
Because the liver is not detoxifying the
So liver is not detoxifying, huh? So that's why we have more ammonia. Any other reason? Any other contributing mechanism from voice?
Bacteria.
Higher protein intake maybe.
Okay, but generally, like assuming the same protein intake, like we don't usually restrict the protein intake, but we don't give it like too much protein. It's a normal diet, but and bacteria still like suppose the same chronic flora, but now there is conversion and there's ammonia which is not being detoxified as our fellow student said.
Also shifting from the blood flow from the liver to the autostomach side.
Very good. That's what I wanted to know. Yeah. So one thing is liver is not working; it's not detoxifying. The other thing is there are portosystemic shunts, and you know this patient has portal hypertension, has history of esophageal variceal bleeding. That means he has varices as well. So there are portosystemic shunts. So when the blood gets shunted to the systemic circulation, bypasses the liver. So whatever the function of liver is left, the blood is not going and it's to the liver directly going to the systemic circulation. And hence, there is a procedure which probably you might have done with the clinician. Yeah, so tips. So tips we do to reduce the portal pressure, because when there's too many episodes of variceal bleeding and other issues, but that will increase the risk of hepatic encephalopathy. So name the first line therapy or drug which can improve his mental status.
Lactulose.
Very good, lactulose. So how would that drug work? Like how would that improve his mental status?
Conversion
1% at a time. Okay, so from girls, because lactulose came from boys. So where's this increased acidity coming from? Yeah, so lactulose will be converted to lactic acid. So low pH or more acidity in the gut. Yeah, so it will convert the ammonia to ammonium, which is not just blood brain. It will not be absorbed from the gut. Also, that part is true when it's in the circulation. Then when we talk about the conversion in the circulation, here we are talking about conversion in the gut. So ammonia is absorbable from the gut. Ammonium is not. So ammonia is what? NH3 and H4.
H4.
Ammonia.
Ammonia is NH3.
NH3. Ammonium is NH4. So one more extra hydrogen. So you need more hydrogens to come. So that's why reduction in pH or acidification means more hydrogen available. So ammonia will get converted to ammonium, which will not be absorbed and will be excreted with the feces. So it will get rid of through the feces. So that's the main mechanism. But then there are a few other things which lactulose does. Do you remember those things from voice?
It causes modification of bacterial flora.
Good, very good. So it converts the from urease producing bacteria shifts to non-urease producing lactobacilli. Very good.
And also it decreases the production of short chain fatty acid.
Good. And major thing that
Increased
lactulose
sodium
does.
excretion.
Yes, so it because it's causing diarrhea, so it is decreasing the transit time. So it doesn't allow enough time for the ammonia to get absorbed. So even if there is ammonia which is not converted, it will not have enough time to get absorbed and to get rid of go out of the gut. So there are a few things which it does, but the major mechanism is acidification and conversion to ammonia. Good. So suppose you put this patient on lactulose, and still after 48 hours his mental status is not improved. So is there something else that you can add to his? So what?
Not rifampicin.
Not rifampicin.
Rifaximin.
Yes, rifaximin. So you can add rifaximin. So you don't stop lactulose. You continue with lactulose and you add rifaximin. So what is this rifaximin?
It kills the ammonia producing bacteria.
How does it kill the bacteria?
Antibiotics.
It's an antibiotic, huh? So it does it like work like in the lumen as a local effect,
It is not
or is
absorbed.
it going to the system?
It's not absorbed.
It's non-absorbable, huh? So it doesn't go in the system much. And do you remember the mechanism?
Yes.
RNA. It inhibits the synthesis of RNA,
Yeah,
RNA it inhibits the transcription through blocking the bacterial DNA-dependent RNA polymerase.
Similar to rifampicin.
Yes, similar to rifampicin. Okay, so this is like one of the major therapies in hepatic encephalopathy, and also in IBS now they are using this same antibiotic because again in IBS there is a role of colonic flora.
When we were entrance, we used to use aminoglycosides, especially neomycin.
Yeah, so the other question is what other so suppose if you are older times or if you don't have rifaximin, so what other antibiotics might be used to help with the encephalopathy?
Neomycin, oral vancomycin,
One more.
amoxicillin.
No. Which is probably the second antibiotic which I might choose. If I don't have rifaximin, the one that I might choose would be metronidazole.
Metronidazole.
Yeah.
Okay.
So metronidazole, if that's not available, not working, then I might go with omeprazole. So when you have metronidazole available, working, then you go with that. If that is not available, then you go. And neomycin was very widely used, but because of side effects, now we have better alternatives available. But that's also an option. All right. So we discussed because of the distended abdomen, you said ascites. So how do you treat that condition? Ascites, we discussed the mechanism of ascites, and you know there's more aldosterone, that's what you said. So how do you treat this thing?
Propranolol.
Ascites.
Just treated with
Your friend said that, huh? Spironolactone, like as a to get rid of the excess. So there's excess fluid in the body. There's pedal edema, there's ascites. So you want to get rid of excess fluid. So one thing is you put them on diuretics, and the diuretic of choice should be spironolactone. Why?
Potassium
Potassium sparing, huh? Not just that, because these patients have excess aldosterone in the system. So this is aldosterone antagonist, competitive aldosterone antagonist. So you are using the same mechanism. So and also because these patients are more likely to have hypokalemia. So again, this potassium sparing, so that will help as well. So first choice is spironolactone. But if there's a lot of fluid in the body, if somebody is hospitalized, you want to get rid of the fluid quickly, then you can add something furosemide to spironolactone. But you don't send them home on the combination therapy. So like just to get rid of the fluid quickly, you can put them onto diuretics, furosemide and spironolactone, but then you again go back to monotherapy with spironolactone. That's to get rid of the fluid from the body. But the other thing is, as a therapy, if there's a lot of ascites, distended ascites like so gross ascites, so then you want to you want to do paracentesis, you want to remove the excess fluid from the peritoneum, and then you can give, as you said, someone said here, albumin. Because this patient has hypoalbuminemia, and when you're removing this much excess fluid, obviously some albumin is also lost, so you always give them albumin whenever you are removing like 2-3 liters of ascitic fluid. And also giving these patients albumin improves their mortality. Like whether they come with esophageal hemorrhage, whether they come with ascites, or whether they come with hepatorenal syndrome, albumin has a role. So it has a lot of beneficial role. It improves their overall vascular dynamics and the outcome. So we can give albumin, and even suppose if there was not much ascites, there's some ascites, would you still remove the fluid? Some?
No, you will decrease sodium intake.
Yeah, so other therapies you restrict the sodium, you restrict free water, there's hyponatremia, so there are other things that you will do for the treatment. So restriction of sodium, restriction of free water, there's hyponatremia, and then diuretics and paracentesis. But paracentesis can be diagnostic and therapeutic. So therapeutic was when you too much. But even if there's not too much, still you want to the diagnostic one. You want to see what sort of ascites are these. You must have done by this time SAG, huh?
Yeah.
So serum ascitic albumin gradient. So and then you want to look at the neutrophil count. Why you want to look at the neutrophil count?
Spontaneous bacteria.
See if there's any inflammation.
Yeah, so you want to rule out spontaneous bacterial peritonitis. And also you can put them on when they come in with like this kind of, you can put them on prophylactic antibiotic, but if the neutrophil count is more than 250 per ml, then
Third generation.
yeah, so you will assume it to be SBP and you will put them on third generation cephalosporin. That's your initial choice, but once you have the culture result, then you will obviously resolve accordingly.
So
We
doctor,
discuss antibiotics and albumin.
if the neutrophils count are high, so we suspect the SBP.
Yes.
So we change the treatment from ascites treatment to SBP.
No, we will treat the ascites, but we will add antibiotics for the treatment of SBP. SBP can be asymptomatic. It can have symptoms. SBP can even present with hepatic encephalopathy because hepatic encephalopathy always there are underlying precipitants as well, precipitating factors. One of them is infection or SBP. So he might be having SBP. So you need to rule it out. So if the neutrophil count is, so they may not have even fever. So if the neutrophil count is more than 250, you will put them on antibiotics for the treatment of SBP. The prophylaxis you can give them fluoroquinolones and these things. So what is the cause of repeated episodes of metamesis? Varices, which are due to portal hypertension. We discussed that. So what drug can be used to prevent or reduce the risk of hematemesis? Octreotide when, yes, octreotide you're right, but when they are bleeding, when they present with the hemorrhage,
Beta blocker.
then you put them out. When you want to prevent or reduce risk, so which is prophylaxis. So for prophylaxis, what do you use?
Beta blocker, non-selective.
Yeah, non-selective beta blocker. And you remember why non-selective?
Beta, B2, beta 2.
Yeah, so you want to block the B2 as well. And which non-selective is most commonly used? Propranolol, which will reduce the portal pressure as well as reduce the risk of. So it can be used in for someone who never had variceal bleeding, but you know they have CLD and they have esophageal varices, but no episode of hemorrhage. You can still put them on propranolol to prevent the episodes. So that's called primary prophylaxis. Somebody who has a repeated episodes, then it will be secondary prophylaxis. But secondary prophylaxis would not only be the drug, but they would also do some procedure as well, which I did not cover. Like they will do the band ligation of esophageal varices if someone is having repeated episodes. Octreotide, as you said, so how would octreotide work?
This somatostatin analog.
Yes, somatostatin analog.
So it causes vasoconstriction.
Same. So somatostatin analog causes vasoconstriction, splanchnic vasoconstriction, and good. So, but we don't use it for the prophylaxis. So if someone presents with hemorrhage, so they are given octreotide, and then there are other vasoconstrictors like terlipressin and those things which I did not cover. So that the pressure is reduced acutely and there's less hemorrhage, so they can go in and do the procedures and they can be put on octreotide for 3 to 5 days. But that's during the acute episode. So for this you want to be? Yeah.
We are doing okay, see the case. Chemotherapy, after chemotherapy, etoposide, this 60 to 66-year-old man presented with nausea and vomiting. His symptoms improved significantly after administration of metoclopramide. Okay. Patient's symptoms were most likely because of chemotherapy on area posterior, specifically.
Fourth ventricle.
Hmm?
Fourth ventricle.
NK1.
Area. structures in the brain.
So if there's someone is saying it,
Chemoreceptor triggers. Vestibular nerve. If vestibular nerve is affected, stimulated, what type of vomiting would you experience?
Isn't that yeah, motion sickness,
Motion sickness, merry-go-round. If your intestinal and smooth muscles are stimulated due to distension or some irritant, what type of vomiting would you experience? Yes. And which receptors would be involved? Serotonin, dopamine as well. If vagus nerve is stimulated, that means acetylcholine, and then in turn vagus nerve will stimulate solitary tract nucleus, and then it will directly stimulate vomiting center in the middle of the brain. Cerebral cortex. What type of vomiting would you experience if you had something to do? Pathway comes from cerebral cortex. Emotional, or we call it recall vomiting also. Recall vomiting. Have you ever experienced something dirty, bloody in the past, and you experienced vomiting at the time during that incident? Many years later, the thought of that incident is sufficient to trigger vomiting only. Okay? That is also in chemotherapy induced vomiting, for example, there is another term. First time you experience vomiting as a result of administration of anti-cancer drugs. After a few times, you just enter into the hospital, the thought of that you are going to be administered anti-cancer drug, even though before the administration you enter into the ward, you start vomiting. What is that? Emotions are attached, but that is known as anticipatory vomiting. You anticipate now. Oh, the drug is going to come, and it will start vomiting. Even in anticipation, you will start. So those pathways are coming from the cerebral cortex, higher centers. They are stored in your memory. Okay? And that type of vomiting is treated with sedatives, hypnotics, cannabinoids, and neurokinin receptor antagonists. Cannabinoids, even corticosteroids, dexamethasone. So what is the answer to this question? Area posterior, specifically chemoreceptor trigger. Once again, chemotherapy induced vomiting.
Neurokinin, cannabinoids,
Okay, neurokinin receptor antagonist.
antidopamine as well. Antidopamine, right?
Antidopamine or
Antihistamine, metoclopramide, and triptan.
okay. Somebody mentioned the antihistamine. Who raised your hand? Who did? Why do you think antihistamine should be used?
Because it crosses the blood-brain barrier.
So what?
I think antihistamine is related to motion sickness.
Give sedation.
Think about the various diverse stimuli leading to vomiting. The stimulation of vomiting center, stimulus coming from here, coming from here, coming from here.
Just focus on the main.
So receptors are different. Okay. 5-hydroxytryptamine receptors coming from the GIT, coming from the solitary tract nucleus, coming from the chemoreceptor trigger zone. Dopamine receptors coming from the GIT, coming from the chemoreceptor trigger zone. Muscarinic histamine receptors coming from the vestibular, not from the chemoreceptor trigger zone. Cannabinoid receptors and benzodiazepine receptors coming from the cerebral cortex. So in those situations, each type of vomiting has to be treated accordingly.
I think we've shown it in so many images. If we go back to the slides and we show the receptors expressed in each area, the vestibule in the stomach, in the chemoreceptor trigger zone, vomiting center, and cortex. If we go and revisit that, that will help us to say no at least to certain options, okay, like antihistamine or, okay?
They use
Headaches and so on.
Headaches and constipation. Which medications, which you mentioned, there is medication. Dopamine.
Headache and somatostatin.
Somatostatin is not an antibiotic.
Headache and constipation. Yeah, headache and constipation for somatostatin.
Which one?
serotonin.
But antimuscarinic work is not used in chemotherapy-induced vomiting.
Maybe steroids.
Headaches, think of headaches.
Steroids.
Serotonin receptor antagonist.
Yeah.
Serotonin receptor antagonist.
Yes. Either serotonin receptor antagonist or steroids. One of them.
Steroids, why would the steroids cause headache and constipation? Why would they cause constipation?
Yeah, steroids is given as antidote.
No, why would they cause constipation? Steroids will cause constipation. Based on the side effects, you have to figure out the drug which was given to this patient. Initially, you identified mainly two classes of drugs which could have been used to prevent that vomiting caused by chemotherapy. You mentioned NK1 receptor antagonist and serotonin receptor antagonist, didn't you?
I think there are four types. Cannabinoids, NK receptor.
You see, first of all, appreciate the difference between cannabinoids and the treatment of acute vomiting caused by chemotherapy. That needs to be treated with serotonin receptor antagonist or NK1 receptor antagonist. Are you with me? But if you are going to treat anticipatory vomiting in the subsequent experiences, that needs to be treated with cannabinoids, not the acute. Anticipatory vomiting, which is mainly concerned with your memory and your emotions. The higher pathways are involved, not the chemoreceptor trigger zone directly. Cannabinoids does not have any effect on the chemoreceptor trigger zone. The vomiting comes from the higher center based upon your experience. Anticipatory vomiting. That needs to be blocked with cannabinoids, not on the first instance, but for the subsequent. Is that clear?
So if you have to pick one antiemetic,
Serotonin.
yes.
On this drug.
Yeah, so which serotonin receptor is it? 5-HT? 3. So it's 5-HT3. So the first line management would be
On that strong.
5-HT3 blocker. So always, like, whenever you see any question on, like I'm talking to USMLE, not this example, like, so chemotherapy induced nausea vomiting, the first line is 5-HT3 blocker on serotonin or other as well. And so one of the side effects of 5-HT3 blocker is
Constipation, headache, serotonin syndrome.
We discussed already. Last but not the least.
Just refused to.
this is
Oh.
yes. So do you want me to read this?
Bloody diarrhea.
Okay. So you have a 16-year-old boy. He comes to a physician because of 3-week history of loose stools. So 3-week history. Huh? So is it acute or chronic?
Persist.
Acute.
3 weeks.
Less than 4.
Less than 4 is acute.
Persist.
But it's not acute. Like, say, suppose some infections or food poisoning, they will present like 1 day history of diarrhea. But this is 3 weeks. So it's not that sort of acute. It may be like in the broader definitions, maybe like acute, but like it's not an infection type of acute. Like suppose food poisoning or E. coli infection or viral diarrhea, will that present with 3-week history? No. Huh? So this is a 3 week history. So, and there are 2 to 3 episodes of loose stools a day, and occasionally bloody. So it's a bloody diarrhea for 3 weeks. And he also had crampy abdominal pain, generalized fatigue, and 2 kg weight loss. So what do you think? So there's a weight loss, there's fatigue, there's abdominal pain, bloody diarrhea for 3 weeks. Sorry? So you're thinking of IBD, inflammatory bowel disease. Any other thoughts from this side?
Ulcerative colitis.
So that's IBD. So it's one of the IBD. So ulcerative colitis or Crohn's disease. So that's IBD.
Ulcerative is bloody.
Sorry?
Yes.
Anything else? Oh, can this be an infection? Highly unlikely because this has been going on for 3 weeks. But there are some infections which might go on for a longer period. Can you name one which might have bloody diarrhea?
Infections into amoeba.
Amoeba. So amoebiasis, amoebic diarrhea, again should not, patient probably won't be able to wait for 3 weeks and it will be more like frequent. But yes, if it goes on, it can be bloody diarrhea with mucus and abdominal cramps. And if it's going on for this long, so it will can produce weight loss as well. So that's one possibility, but distant possibility, less likely. Okay. Otherwise, you're thinking of inflammatory bowel disease. Okay. Any other cause of diarrhea? Which? Ulcer?
Cause of diarrhea.
Yeah. Which? Could this be irritable bowel syndrome? Would irritable bowel syndrome have blood?
No, this is what
No.
it is.
Huh? So it won't have bloody diarrhea. So it doesn't look like irritable bowel syndrome. Could this be celiac disease, which will have weight loss, fatigue, and all those things?
Without blood.
Huh?
No blood.
No blood. So again, you don't expect blood. Okay, now you have like normal temperature, normal pulse, pressure is slightly lower, but it's okay. This mild lower abdominal tenderness and palpitation. So still you're thinking of? Okay. And then we have distinct possibility of some parasite like amoebic dysentery, but like the stool microscopy for ova and parasites is negative. So now kind of makes it less likely, much less likely, you know. So now we are left with mainly with probably IBD, huh? Okay, his hemoglobin is slightly low, WBC count is slightly elevated, ESR is okay, 14. So we don't have many systemic features here. So there is some anemia, little anemia, but ESR is okay, there's no fever. Then we did colonoscopy, okay? And we saw inflamed tribal mucosa extending just beyond the rectum that bleeds on contact with the endoscope. A biopsy confirms the diagnosis. So what is the diagnosis?
Ulcerative colitis.
Ulcerative colitis. Why?
Because of the bloody diarrhea.
But why not Crohn's?
Also beyond the rectum.
So one person at a time. Okay. So one difference from female side between Crohn's and ulcerative colitis. So what makes you say it's ulcerative colitis? Yes, so it starts from the distal most part. So it starts from the rectum and then progresses proximally. So you see the rectosigmoidal area, rectal involvement. Okay, that makes it more likely.
This hair is only for mucosa, so it's not penetrating the whole layer.
Yeah, so if they are talking about mucosa, so yes, so they are not saying deep ulcers. Okay, so we don't see any deep ulcers. Okay, that's another reason. But that again on biopsy you will see is it transmural or is it just limited to mucosa and submucosa? Okay, and on biopsy you might see something else. We'll come to that. Okay, so yeah, another difference. Yeah, but both of them have systemic manifestations. In early stage, in mild disease, they may not have systemic manifestations.
Ulcerative colitis is more known with bloody diarrhea more than Crohn's disease.
Yes. So it's more associated with bloody diarrhea. Crohn's can also have bloody diarrhea, but like less likely.
Also, ulcerative colitis has a higher risk of cancer.
Yeah, but like this is the beginning, so we don't know. Well, so this is based on the features here. But you should know the other differences between Crohn's and ulcerative colitis. This is very high yield area. The difference between Crohn's and ulcerative colitis. This is very like frequently tested topic in USMLEs and other board exams. Yes. Sorry? Yeah, fragile mucosa. goes more with ulcerative colitis. Good. Yeah. So this is ulcerative colitis. So most of you are saying this ulcerative colitis, and that includes tribal mucosa, and what you will bleed if you touch it with the endoscope, because it's tribal. And usually are the skip lesions would be a feature of
No.
Crohn's. This is more contiguous, circumferential contiguous, and Crohn's can involve
The oral, the small
all J,
Yeah.
yeah, all J. And but this one
It's only limited to the colon.
up to what?
The ascending.
Up to the cecum.
Up to the cecum. So it's mainly the colonic disease. So approximately it can maximum go to maximum to cecum. Like sometimes they call backwash ileitis, so terminal ileitis very rarely can happen. Otherwise, only colon. It's limited to colon. Okay. So you have the diagnosis, which is ulcerative colitis. So now you know, is it like a mild disease, moderate, severe?
This is
Moderate?
Huh? 12 minute
Moderate?
is moderate.
the patient developed anemia and his dose.
Not much anemia. It's 11 point.
Moderate.
Moderate.
Moderate. Why? How many lose stools for moderate?
Oh,
It's 2 to 3 lose stools.
this is mild.
This is mild.
Mild.
You don't have many systemic features. There's no fever. ESR is less than 30.
More than 6 is, I think, moderate. More than
No,
10.
no, it's more than 5 is severe. 5 comes in between, which is like between severe and mild. So moderate would be around 5. Less than 5 is mild. Less than 5 is mild. So there are many other features. It's this mentioned in your clinical lecture, I think. Yeah, so just go over that. So mild is less than 5 stools. More than 5 stools is severe, in between, and then you need systemic features. So this is mild disease and at first presentation, and we don't have any systemic involvement, and we don't like ESR is also less, and we don't have any other complications of the disease. So it's not high risk at the moment. So what would be your appropriate most like therapy? What would you use?
Mesalamine.
Mesalamine. Girls at the back, what would you use? Girls which are busy with their devices. Okay, boys at the back. Okay, your friends are saying mesalamine. Do you agree with that? Okay, how would you use mesalamine? Would you give it like orally or?
Can you repeat the question?
How would you give mesalamine to this patient? You will give oral mesalamine tablets, or you will
Yeah,
give
oral.
some other route?
Because it's poorly absorbed, so it will have more local effect more than systemic effect.
No, yeah, mesalamine works locally, topically in the colon, but you want to give it orally, it can get absorbed through the, depends on what you're using. So, okay, so suppose it goes to the colon. But in this case, can you give mesalamine enema? Or you can give mesalamine suppository?
Yeah.
Because this is only limited to rectum, or is it
It is only in the rectum.
just beyond the rectum? So a little bit of sigmoid probably, huh? So would enema work here? Yeah. So based, suppose you do not have the diagnosis, so gluten-free diet, would that work in this patient? And which disease you use it? CJ. Good. Proctocolectomy. When do you do this?
Severe cases.
Hmm?
Toxic megacolon.
When there is like severe pancolitis refractory to the medical therapy, or there are complications or contraindications to medical therapy, colorectal cancer, so then you go for these things. So in the mild, low risk disease, no, you will not do this. And all of you are saying mesalamine therapy. Okay, so mesalamine would be your right choice. We will go over mesalamine and these things. Prednisone therapy? Would you use prednisone?
If it didn't work.
If this doesn't work, or suppose initially when would you use prednisone?
For maintenance,
Maintenance, you don't want to give steroids for maintenance.
in the induction.
For induction. So we are at the moment doing induction kind of thing. But even for induction, would you use prednisone in this patient?
More
In a
severe
mild
cases.
disease, do you use prednisone?
No.
No.
We use it in more severe cases.
Hmm?
More severe cases.
Yeah, so moderate to severe cases. Even like if you want to use a steroid, this would not be your first choice. Prednisone will come like when you're moderate to severe. So other things haven't worked. We'll go over them. Infliximab therapy. In steroids, do you know budesonide?
For asthma?
Or
So that I don't know about asthma, but like here it's used in
that's right.
the inflammatory bowel disease, especially in ulcerative colitis. So initially, probably you might go with that, and then if that doesn't work, then you go with oral prednisone and then IV steroids. Infliximab,
Also same.
yeah, it goes into the, like severe, which is a steroid refractory. What is infliximab?
TNF.
TNF alpha blocker, huh? Inhibitor. Okay. And anything particular, like any side effects of infliximab? FB?
Reactivation.
TB reactivation. TB reactivation, very good. Cyclosporin therapy?
In severe cases.
Yeah, in severe refractory cases, you will go with like the ones which are not responding to steroids and the biologics, then you will go with cyclosporin. Okay. So goals of IBD therapy would be, because we did not have a lecture on this thing. Some years back we used to have one lecture, but then we removed it because the clinician covers it, so we thought like, and you have PPL as well. So just few slides to cover here. And that's why otherwise it would have been just a cases. So you want to achieve, the primary goal is to achieve mucosal healing and induce remission. And you want to maintain these patients without steroids. So you want to have a steroid-free remission. So during remission, they may not require treatment. If they need treatment, so you want to give treatments, other treatments like mesalamine, those things to maintain the remission. You don't want to give steroids. So you want to have steroid-free remission. And obviously there are complications of this disease, IBD, so you want to prevent those complications, and you want to avoid short and long-term toxicity of the therapy, as well as you want to enhance the quality of life. So what are different options that are available? Antibiotics have some role in the management of which ulcerative colitis or Crohn's? Crohn's. And that's again for the management of the perianal and fistulating disease and that part. But the disease activity, antibiotics don't have much. So we talked about mesalamine, so 5 ASA compounds. What else?
Corticosteroids.
So steroids, huh? What else?
Azathioprine, mercaptopurine.
Azathioprine, okay.
6 mercaptopurine.
6 mercaptopurine.
TNF antagonist.
Yeah, infliximab, and then there are the biologics and cyclosporin. Good. So we have all this. So we have 5 ASA compounds, aminosalicylates, and then we have glucocorticoids, immunomodulators, and biologic therapy, which includes TNF alpha therapy. Now in this pyramid you can you see again you have another pyramid in the clinicians lecture. I think that one is better, which takes into account the risk factors as well. So you treat it based on the low risk versus high risk and the disease severity. So both things can be taken into account. So you always start with 5 ASA compounds. Antibiotics have some role in Crohn's, and then you will go with topical corticosteroids, and then you can go like proctitis, budesonide can be used. Why we use budesonide?
Oral. Short half-life.
But prednisone is also oral.
Short half-life. Absorbed.
Yeah, so there are preparations which let it release, so it's released towards the ileum, towards the end of the ileum and colon. pH dependent release. And what happens, so it works over there, it gets absorbed, but then there's extensive first pass metabolism. So there are minimal systemic side effects. So we avoid the systemic side effects of these. So just a little bit about 5-ASA compounds. I have uploaded some slides in the Moodle and I emailed you as well. Okay. So I haven't put all those slides here. So 5-ASA, this is aminosalicylates, 5-aminosalicylic acid. Now don't confuse this another ASA, acetyl salicylic acid, which is aspirin. So aspirin is acetyl salicylic acid, which is also called ASA, but that's aspirin. So the parent compound is salicylate, but this is aminosalicylate, 5-aminosalicylate, 5-ASA, which is a generically it's mesalamine or mesalazine. But when you, in the beginning, like when you, if you just give simple mesalamine of 5-ASA, it will get absorbed through the ileum, won't reach the colon. And as we said, this is more of a topical. It works more topically, so rather than systemically. So you want to make sure that it reaches the colon if it is ulcerative colitis. So initially they combined it with other things. So we had sulfasalazine, that was the first drug that they were using, which was combined with sulfapyridine. But the sulfapyridine would get absorbed and would produce lots of side effects, which I don't have that slide here, but I have a printout. So you remember the side effects? So there are many like sulfapyridine side effects, which were with sulfasalazine, but now we have some preparations with the the mesalamine, which don't get absorbed in the small intestine, and they reach the large intestine. So we use them. So we are avoiding those side effects. Some of them, like still people might ask you, and reversible oligospermia was one of them, like for the sulfasalazine. There are many other like nausea, GI upset, headaches, bone marrow suppression. There are lots of side effects. And then there are hypersensitivity reactions which might cause pancreatitis as well. So you might see pancreatitis somewhere. The other salicylates don't produce those side effects. And but interstitial nephritis has been reported with mesalamine. And so that you should know. Mode of action of 5-ASA. Do you remember that? Again, it's more of an anti-inflammatory, local anti-inflammatory. Exact mechanism is not known. You can read, I have written the details over there. So it works again similarly to aspirin on the leukotriene as well as prostaglandin pathways, and suppresses the inflammatory cytokine release, and also it's free radical scavenger. But again, many things are hypothetical. Okay. So let's talk about corticosteroids. So now corticosteroids, again, if there is mild to moderate disease, mesalamine is not, so you can give budesonide, which again, as I said, there's extensive first pass metabolism, so less systemic side effects. There are many preparations like CIR, budesonide, MMX, you don't need to worry about that. But this is your initial choice. But if that doesn't work, if it's moderate to severe disease or severe disease, then you can go with oral prednisone or IV corticosteroids. Okay? And then you have immunomodulators like marcaptopurine or azathioprine. Methotrexate has a role in Crohn's maintenance as well. And then your biologics like anti-TNF infliximab and the anti-integrin and anti-IL-12, IL-23, which has a role in Crohn's, severe Crohn's. Okay? We have another case. Let me see if there's something else that we need to know. And then there was a slide about which you don't need to memorize anything in that slide, which was extra slide. It's just for information, different preparations releasing at different places. Okay. So this case, 28-year-old woman, she's a known case of inflammatory bowel disease. This is the last case. And she's 2 week, now she has a 2 week history of worsening abdominal pain associated with bloating and non-bloody diarrhea. So we haven't told you like which IBD it is, huh? Okay. And there's decreased appetite resulting in 3 kg weight loss. Colonoscopy 2 months ago showed cobblestone-like appearance. So what is this? And what sort of appearance is associated with ulcerative colitis? pseudopolyps, and there's a loss of
Mucosa.
ostra, so lead pipe, loss of ostra, so lead pipe. This appearance is with, and there were mucosa with deep edematous, so appearance of mucosa with multiple edematous deep ulcers because it's transmural in the sigmoid and ascending colon, so it can involve sigmoid and colon as well. And biopsy showed transmural inflammation, non-casetic granuloma. So there are, so it's a granulomatous disease. And that is the reason why it leads to fistula forming. So, and she was treated on oral prednisone. It was started 6 weeks ago. So she has been on oral prednisone, not budesonide. She has been on oral prednisone for 6 weeks, and she is still again for the 2 weeks she is having flare. So she is on steroids, and she is having flare. So now you need to go to the next step. And she has fever, so 38.5 degrees Celsius, and blood pressure is okay. Abdomen is diffusely tender, but no guarding the rebound. So, and there's perianal fistula, so it's a fistulating disease. So again, that changes your approach. And there's a diffuse reddish nodule on the shins bilaterally. What is this?
Polyarthritis.
Erythema nodosa. And the other skin manifestation you might see, pyoderma gangrenosum. And her this, knee and spine movement is also limited by pain. What is going on? So there is some arthritis, so enteropathic arthritis, maybe ankylosing spondylitis, but in knees as well. So some arthritis again. So you have external manifestations. You have Crohn's disease with external manifestations, systemic involvement with fever, and she's on steroids, so refractory to steroids, so she's on oral prednisone, and she has fistulating disease. Okay, so keeping that in mind, so you give the diagnosis. So now, what would be the appropriate therapy? Methotrexate. Usually that goes for the maintenance of the remission in Crohn's. So this is steroid refractory fistulating disease. Yeah, but like that won't take care of the disease itself. Like so she has steroid refractory disease. She is having diarrhea and systemic involvement. So you need to give something for the Crohn's disease as well. Antibiotics will help only with the fistula part, little bit, but again it's a part of management. Again, for fistula, she needs the primary treatment of Crohn's disease. Yeah, so immunomodulators or immunosuppressants, you need to go in that is not beyond steroids. Steroids refractory. So cyclosporin A, will that work here?
No. It's not severe. So.
Yeah, it's more with the ulcerative colitis and severe ulcerative colitis. In Crohn's, cyclosporin doesn't have much role. What about infliximab as a therapy combination? Yeah, this is what you use. So in such cases where you have fistulating disease, you have like severe steroid refractory, you can go with the monotherapy of infliximab as well. That's again gives you similar results, but again you can also use combination of infliximab and azathioprine. So that's the appropriate therapy here. What about this budesonide therapy? CIR is like controlled ileal release. So you don't want the budesonide to be released in the small intestine. Like towards the terminal ileum where it will work on the terminal ileum and yeah, so she is taking oral prednisone which is not working for 6 weeks, so budesonide will not work. This will, like suppose you give somebody the saline doesn't work, you can go to budesonide. Okay, but someone is on oral steroids and fistulating disease, so you will go with infliximab as a proctocolectomy. Those things will again go with ulcerative colitis, not with the Crohn's part. Again, like this can be curative in ulcerative colitis as we discussed previously. And again, this is not the initial therapy. Surgery, there are indications for surgery, which we discussed. Okay. Sulfasalazine therapy, will that help? No? Sure? Yeah. So again, for the induction, like steroid refractory, even if it was ulcerative colitis, it will not work. Only in mild ulcerative colitis, induction can be with the sulfasalazine rather than the mesalamine. But in this case, when you have fistulating disease, sulfasalazine will not work. And steroid-refractory, so the answer would be infliximab as a favorite combination therapy. Okay?
Finally, the last case. This is also not very a 65-year-old male presented with tremors, rigidity, and bradykinesia. Your diagnosis is that of a Parkinson's disease. Parkinson's disease. You prescribed a combination of levodopa and carbidopa. Do you remember from neurosciences?
Yeah.
The patient returned a few weeks later and told you that he is feeling great improvement in rigidity and bradykinesia, but he has developed severe nausea and vomiting.
Dopamine.
Dopamine agonist.
They know that is so
They didn't even.
without asking the question.
So the question will be why domperidone?
What is the mechanism underlying this adverse effect?
D2 receptors activation.
It chemoreceptor trigger layer of postima. So how do you overcome? Don't worry.
Why not metoclopramide? Why not metoclopramide? Hmm? Which one crosses blood-brain barrier? Huh? Metoclopramide or domperidone?
Domperidone.
Okay, metoclopramide will cross blood-brain barrier. And you don't want the first to cross blood-brain barrier?
Yeah, because we're giving
Parkinson treatment, huh? So if the domperidone doesn't cross blood-brain barrier, how will it work as an antiemetic? How will this get to cardiopostema?
No.
It will get visible before going outside.
Yes, she is right. Outside.
Oh, out there. So yeah, so cardiopostema is like the blood-brain barrier is lacking over there. So there are fenestrated capillaries over there.
Okay, with this, we are done. Thank you very much. And God bless you. Good luck with your examination. Thank you very much.
Thank you, doctor.
Do you need this presentation or not?